Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Helping Smokers Quit web conference. I would now like to turn the floor over to Ms. Marjorie Wells, who will help explain this program.
Greetings to everyone. Welcome to a presentation of Helping Smokers Quit, a national program just for nurses in West Virginia, Indiana, and California, and funded by the Centers for Disease Control and Prevention. The speakers are Dr. Linda Sarna, Professor of Nursing at the University of California, Los Angeles School of Nursing, and Dr. Stella Viallos, President of Tobacco Policy International in San Francisco, California. Both Dr. Sarna and Viallos are nursing leaders in tobacco control who've done extensive research and teaching all over the country and in various places in the world and are internationally recognized experts in the field. Their presentation will last approximately 40 minutes. And please note that you do not need to take notes during this presentation because we will have the talk available for download on the Tobacco Free Nurses website, Helping Smokers Quit page. Also, please feel free to write down any questions as we'll have a question and answer period at the end of the presentation. And we would really like to hear your questions, so we'd really like to encourage you to ask questions. Now I'd like to introduce Dr. Linda Sarna.
Hello, everyone. Thank you very much, Marjorie. It's helpful to know who's on the other end of the line. Here I am. Here's Stella, who's in San Francisco, and here's Marjorie. You may want to remember that face in case you have any questions about the program as we go forward. Thank you so much for being involved in the web conference today. This web conference is really to help you understand about tobacco cessation interventions. We want all nurses to have the knowledge and skills to provide evidence-based tobacco cessation interventions to their patients. Many nurses did not have this content in schools of nursing. There are many myths and misperceptions about tobacco cessation. Even if you've quit or you know someone who's quit, they may not have the most recent evidence of the best strategies to quit. We also want to tell you about some important resources that are available over the internet, the tobaccofreenurses.org website, and the special tab on that website, Helping Smokers Quit, that is available just for people who are in this project. Now I'm going to be turning the baton over to Stella. She's going to provide you with a little information about the devastating health impact of tobacco use, provide a foundation for understanding nicotine addiction, and then I will follow up with providing you with a description about the best strategies to help smokers quit. Stella, take it away.
Thank you, Linda, and hello, everybody. Thanks again for joining us this afternoon. We really appreciate your interest and your time. So our project in the end is to help change what a good nurse does. It's all about changing good nursing practice and provide excellent quality of care to our patients. Used to be, and this photo is from a magazine right around World War II, that part of what a good nurse did was to help patients smoke. So this is the photo. We see the nurse helping the patient lighten up, and we thought, oh, let's help the patient feel better, relax. We now know that, of course, good nurses help patients quit and not help patients smoke. There are, as Linda said, still some myths and misconceptions related to talking to our patients about quitting. And one of the issues we have is sometimes we feel bad about it. We don't want to bring up the issue of quitting. The patient might be too stressed out to be in the hospital. In some psych settings, there's still some resistance to talk about smoking in patients that have a diagnosis of a psychiatric diagnosis or some other mental illness. However, we now know that good nursing practice, in fact, requires that we provide cessation. That requirement has been emphasized by the fact that the Joint Commission requires every accredited hospital to provide cessation intervention for patients with heart attack, heart failure, and pneumonia. And because of that Joint Commission requirement, and because a lot of times it is nurses who are providing these interventions, the more we know about cessation, the better equipped we are to provide cessation, the better the nursing practice. The slide is to remind us that smoking remains the leading cause of preventable death in the United States. Many of us know about smoking and lung cancer. Maybe a few of us know that, for example, smoking is related to 32% of the cardiovascular deaths in our country. It is one of the leading causes of preventable deaths from cardiovascular diseases. So even though we all think, oh, everybody knows it's bad for you, maybe few of us know just how bad it is. In California alone, almost 38,000 deaths every year, entirely preventable, are caused by smoking. But there are some good news, and these are some of the good news. Smoking prevalence is going down. Now about 1 in every 5 adults in the United States are currently smoking. The number is slightly lower for women. However, before we celebrate too much, there is a little bit of cause of concern because the line of decline is starting to look a little flat, and we don't want these numbers to stay at this level. We want them to keep coming down and accelerate the decline of the prevalence of smoking. The year 2010 healthy people goals are for 12%, so clearly we're not going to reach that goal, but we nurses can help the country get closer. Another very important thing to remember is that 70% of people who smoke want to quit. So if by any chance you still have any doubts about talking to your patient about quit smoking, remember that 7 out of 10 times they actually do want to quit, and even those who do not want to quit, they actually do expect nurses and other healthcare providers to talk to them about smoking, particularly when they are hospitalized. This is even better news in California. We know that in California, because of all the policies we have had, we are doing better in the rest of the country, so about 14% smoking rate among adults. However, again, a little concern here. If you look that the decline is starting to plateau and look flat, and we want that to keep coming down until we reach that 12%, that is the year 2010 goal. So again, there is a lot of success, but we are not quite ready yet to just enjoy the successes we had in California. I'm going to go over with a lot of facts and numbers. Please do not worry about writing them down. As Marjorie said, this PowerPoint will be available on the website for you. These numbers is also available on the toolkit that if you have not received, you will receive soon. And it has a fact sheets for nurses about tobacco issues in California. So like I said, we have made a lot of progress in the overall population. However, what we know is there is still some groups, particularly some ethnic minorities, where smoking prevalence is still higher than the prevalence among smoking among the rest of the population. We also see these differences in the lower income and lower educated. So there is a large group of vulnerable population that we can help. Smoking during pregnancy is the lowest in the U.S. However, we can still bring this number down, 9% still more pregnant women smoking than we want. This is a number of concern for us. Smoking among young adults is higher than smoking among adults in the general population in California. What that means is that we are not going to start seeing that much decline anymore unless we start helping young adults quit as well. A lot of times we think about quitting, we think about our elderly patient, or we think about our middle-aged patient that had a heart attack. However, we have a lot of young people who are smoking more than the older counterparts that need help to quit. Same thing with adolescent smoking. The number, although lower than the U.S. average, still a little higher than we think. And when you think about the devastating health impact of smoking, we also have to think that it has a devastating fiscal impact. Over $9 billion every year is spent in California alone to treat tobacco-related diseases. These are taxpayer monies. They're spent to treat entirely preventable diseases through cessation and prevention of starting. We are lucky in California that about 95% of our workers are protected from secondhand smoke in all workplaces, including restaurants and bars. However, we still see, similar to the smoking prevalence, there is a little discrepancy with protection, with those in lower income and lower education more exposed to secondhand smoke than those in the professional or high income brackets. Cigarette taxes, a little problem for us in California. Cigarette taxes, why do we need to know about that? cigarette taxes are actually, and prices are excellent prevention measures. The more expensive we make cigarettes, the least likely that adolescents and young adults will smoke. They tend to have less disposable income, so it is a deterrent. So it's a very good preventative measure to have higher taxes. However, and all of our measures and our success are happening in face of an enormous power, which is the tobacco industry. Over $800 million is spent every year in California alone. This is just California numbers to market tobacco products. And you may think, no, but we don't have ads on TV and we don't have ads on movies. Well, but we have other types of promotions. You have parties, you have some sponsorships, you still have buy one, get one free. So again, this is all marketing to the tune of over $800 million a year in California. The other very important thing to remember is that although we have made so much success in the percentage and decline of the percent of people who smoke, there is still almost 4 million people in California that need our help in quitting. So we have a large amount of smokers in the state, and they need help with quitting as much as everybody else. This is to remind us that there are two different kinds of toxic compounds in tobacco smoke. There is one that are related to gases, and these are like benzene, ammonia. These are all toxic substances that we put into our bodies, or the smokers put into their bodies when they smoke cigarettes. We also have particles, and the particles are what tend to deposit in the lungs and lead and to all sorts of other illnesses. For example, nitrosamines, polonium. Yes, nicotine is a particle, but however, it's important to remember, nicotine is not what is causing diseases associated with tobacco. Nicotine is what causing addiction to tobacco smoke. In 2004, the Office of the Surgeon General issued an update of the report on the health consequences of smoking. The Surgeon General has releasing these reports for over 40 years now, and every so often when an update comes out, we know a little more about how bad smoking is for you. In this last report, we found out, for example, that smoking harms nearly every organ of the body. Why is that important for us to know? Particularly for those of us working in ER, med-surg clinics, the likelihood that we're going to find a patient who has a smoking-related disease is very high. So it's very important for us to be aware of that link. Quitting smoking has immediate as well as immediate as well as long-term benefits, and so it's always a good time to quit. It's important to know that if you get a patient who says, oh, I'm 68 years old, I've been smoking for 40 years, 2 packs a day, or for 50 years, it's too late for me now, it's never too late, because even for long-term smokers, there are some immediate health benefits. And of course, for those who quit earlier, there's longer-term benefits that they can enjoy. Another important finding is that smoking light cigarettes or mild cigarettes or extra lights do not provide any health benefit. We heard somebody sometimes talking about, oh, I'm switched from regular to lights. That does not provide any health benefit. The lights are designated through a machine that smokes cigarettes and decide how much nicotine and tar the machine absorbs. What the machine absorbs does not reflect what it is that people absorb when they're smoking. And of course, the list of diseases caused by tobacco keeps expanding, and this is the list. Like I said, many of us know about lung cancer and tobacco or heart attacks and smoking, but few of us may know, for example, that bladder cancer is caused by smoking, or that reduced fertility in women is caused by smoking, or cataract, osteoporosis. Again, the chances that we're going to find somebody with any one of these diagnoses is very high, and it's important for us to know whether or not this is caused by smoking. In 2006, the Surgeon General issued another report, this time about involuntary exposure to tobacco smoke. Some people call it secondhand smoke, passive smoking, involuntary smoking, and some people call it environmental tobacco smoke. But what the important point is not the name. It's important to know that there's no safe level of exposure to secondhand smoke. So separating environments between smoking and non-smoking areas is not an alternative. Of course, we're lucky that in California we have 100% smoke-free workplaces almost everywhere. However, A lot of times people interpret this as like, oh, maybe I just go into the stairwell and smoke on the stairs, or smoke by the door, or smoke in the hallway. That is the same as smoking indoors. There's no protection by just going to the room next door. We also, many of us may know, for example, that passive smoking or secondhand smoke is really bad for kids. Increased risk of SIDS, increased risk of respiratory infections, middle ear infections. But now with the Surgeon General report in 2006, we also know that has some immediate adverse effects on the cardiovascular system, and of course an increased risk for heart disease and lung cancer for adults exposure. So it's not just an issue to protect kids, it's to protect everyone. Another point to bring up with your patients when you're talking about quitting might not be the health impact of smoking, but the economic impact of smoking. You already saw the economic impact on taxpayers, but this is at the individual level. This slide tries to show you what a person who smokes a pack a day over a lifetime would have saved if they had put the money towards a low-earning interest account, savings account, for example. But that may also be too much for your patients to try to deal with, like, oh, now it's too late, I don't have another 50 years of savings. So what you can do with your patients is ask them every day to put in a jar the amount of money they would have spent on buying tobacco every 2 days, or how often it is that they buy a pack of cigarettes. And at the end of the month, they can realize how much money that saved, and they can use that money to treat themselves to something they want. It could be taking the family to the movies, to a pizza dinner, buying a digital camera, or something that they've been wanting to have and didn't have the extra cash. So again, that's another thing to bring up with your patients. Very immediate reward from quitting. This slide is to remind us that smoking at any time is a good idea and is beneficial, that smokers on average die about 10 years younger than non-smokers, but any time is a good time to quit. This is based on a study about 35,000 male British doctors that will follow up through 50 years. And we see that the people who quit at about age 30 regain the 10 years of life of that a non-smoker, and that declines a little bit. However, we see that even those who quit after 60 years of age still gain several years of life. So there's always a gain. It's never too late to quit. That's the key message we are trying to get here. It's never too late to quit. Again, this is talking about what I said, the immediate and long-term benefits of quitting. Immediately, you get circulation improvement and lung function improvement. We also start seeing a decrease in the excess risk of cardiovascular disease. Eventually, it reaches that of a non-smoker. We also see an immediate regaining of the normal function of the lung cilia, and that's when the lungs start sometimes gaining mobility, the cilia gain mobility, and help patients cough up some of that debris, some of the particles that have been accumulating. So again, this is all a very short-term benefits. Tobacco dependence, we need to remember, it is actually a two-part problem. It's not just addiction to nicotine, which is very serious, and it exists, and for that there's some medication that may alleviate the need for nicotine, but there is also a behavioral component, and that's the part when the patients have a really hard time thinking about not smoking after dinner, not smoking in the drive to work, not smoking after coffee, and for some of that behavior modification is necessary. So treatment that only addresses one or the other may work, but the most effective type of treatments are the ones that address both the physiological and the behavior aspects of tobacco dependence. And why it is a dependence? Nicotine reaches the brain within 11 seconds. After one puff, nicotine reaches the brain in 11 seconds. Cigarette is the most effective nicotine delivery device ever invented. Nothing else is going to give that quick satisfaction to a smoker who is trying to quit. In about 3 minutes, you see a peak level in the plasma nicotine concentration that ends into a decline. And then what happens is that when it starts declining, the patient will need another puff. In 11 seconds, it reaches the brain again. And that's what happens. Nicotine reaches the brain, stimulates dopamine release, leads to some pleasurable feelings, leads to repeat administration when that plasma concentration level starts to decline, and tolerance does develop. That's the typical path of addictive substance. Very few people start off as a pack-a-day or 2-pack-a-day smoker. They develop that tolerance until they reach whatever is their ideal level to maintain plasma concentration of nicotine. So we have to remember that nicotine is an addiction. It's not a bad habit. It's not something if you have strong willpower you can get rid of it. Yes, just about everybody knows somebody who one day woke up and said, I quit, and never once relapsed, never once went back, and have no problems at all quitting. These are the very, very, very small majority of quitters. The majority of quitters do not quit like that. The majority of quitters have a much hard time, and the majority of people who try to quit smoking need assistance. Nicotine, because it is an addiction, tobacco users will do anything they can to maintain a minimum serum concentration, to maintain modulate mood, to prevent withdrawal, to maintain pleasure, and they will self-titrate. And they'll self-titrate by either smoking more frequently or more intensely, taking deeper puffs, for example, inhaling deeper, or they will, if they try to switch to the so-called light cigarettes, they will cover little holes. These cigarettes, they're lights. They have little holes in the filter to trick the machine smoking them to pretend they have lower nicotine and low tar. And smokers, they know that. They know how to titrate, so they will cover these holes to get the amount of nicotine they need. Because it is an addiction, it has serious and documented withdrawal symptoms, and some of these are, it's important for us in the hospital setting because hospitals are smoke-free. So when our patients who are smokers are admitted in the hospital, they are in a forced quit moment. They are forced to quit. And a lot of times we're going to have patients who have, for example, insomnia or anxiety or restlessness. And we think that might be related to being hospitalized, to their diagnosis, to not like to being there, not being able to sleep in the hospital. But if we try to investigate a little deeper, we may find out that what these patients are having is nicotine withdrawal symptoms for which there is treatment and there is help. Most symptoms do subside within 2 to 4 weeks. However, it's important for us to know that during the hospitalization, we need to address those withdrawal effects because most patients will not be hospitalized for 2 to 4 weeks. And lucky for us these days, there are a lot of approved medication out there that will help against tobacco dependence, will help with that physiological aspect of dependence, and will help the patient focus on the behavior modifications that they're needed. So medication is important because it does improve quitting rate success. And Linda is going to talk to you a little bit more about what medications are available to us. Linda?
Thank you so much, Stella. So Stella's provided you with a background of understanding the health impact of tobacco use and also the biology of nicotine addiction. The good news is that there are more medications available than ever before to help patients to minimize the withdrawal symptoms that they experience when they quit tobacco use. This slide has a listing of the current FDA-approved medications for cessation, and you will see that there is a lot of variety. These include over-the-counter medications as well as prescription medications. And what I'd like to do now is to review these medications and to describe a little bit about their dosage and duration. Again, there's further details on the website. You will find that in your toolkit there is a little pocket guide called Helping Smokers Quit, a guide for clinicians, and it has a fold-out with suggested use for these pharmacotherapy. One of the first medications, nicotine Prolix gum, has been around since the 1980s. It is available over the counter and can be used for up to 3 months while people are quitting. In this case, people take a higher dose if they smoke 25 cigarettes or more and a lower dose if they smoke less. Usually, patients using this particular type of nicotine replacement don't use enough of the product. So you want to encourage them to use up to 24 pieces throughout the day. I will emphasize that this nicotine replacement product, along with all of the other medications on this slide that say nicotine, are clearly replacing nicotine and minimizing the side effects. That means that if people want to continue to smoke or choose to smoke, they need to stop taking the nicotine replacement product, because otherwise they will overdose on nicotine, their heart will race, their blood pressure will soar, and that won't be a good thing. The next is the nicotine lozenge. The nicotine lozenge is a little bit more recent product. It is now also available over the counter, and it's prescribed depending upon the level of addiction. And a good way to assess how addicted a smoker is to ask them their time to first cigarette. If they smoke within 30 minutes upon awakening, they will take a higher dose than people who smoke after 30 minutes. This product is also used for approximately 12 weeks. The transdermal nicotine patch has been available since the 1990s. It is prescribed, it is available via prescription and over the counter, and is used for approximately 8 weeks. It's used with a step-down method, where first a higher dose for the first 4 weeks, and then lower doses for the subsequent 2 weeks, and another lower dose 2 weeks later. The nicotine nasal spray is available. This is a spray to the nasal passages. It's used for about 3 to 6 months. It is available prescription only. The nicotine inhaler also can be used for up to 6 months, and for 6 to 16 cartridges a day, depending upon their tobacco use. And again, they inhale this or suck on this similar to a cigarette. Now, these other two medications, bupropion and varenicline, are non-nicotine replacement medications, and they work a little bit differently. They work to minimize the pleasurable effects of tobacco use. And frankly, people using these products lose interest in smoking. In order for them to be effective, however, patients need to start using them approximately 1 week before they make a quit attempt, so that they can get an adequate blood level, and then they step down to the maintenance dose. These products are used for about 6 months. They are both prescription only, and with bupropion there are counterindications for people with seizure or eating disorders, and with varenicline, also careful observation for any changes in mood or past or psychiatric symptoms. I will say that most people with mental illness and with substance abuse have a much higher prevalence of tobacco use. So it is careful to monitor those patients in particular, but all patients will benefit if they have follow-up during the quitting process. Again, to emphasize, nicotine replacement helps reduce the physical withdrawal from nicotine. It takes away that reinforcing effect, and it allows patients to focus on the behavioral and psychological aspects. Just slapping on a nicotine patch is not as effective as having a comprehensive approach that involves skills training and behavioral support. This slide shows plasma nicotine concentrations. Here, as Stella mentioned, is the perfect nicotine delivery device, the cigarette. Here we see moist snuff also gets a lot of nicotine into the system. Here is the nasal spray with a little spike, but most of the products provide a sustained but continuous release of nicotine over time, which blunts the side effects of nicotine withdrawal. Tobacco cessation requires a behavior change. The hard reality, and the reason we're taking your time today, is only 5 out of 100 people will be quit 1 year later after they've made a quit attempt if they do not use any assistance or medications. That's right, only 5 out of 100. few patients adequately prepare and plan for this quit attempt. And this is where nurses are so important and can make a big difference, because you know that patients just can't make themselves quit, that behavioral counseling and support that nurses do so well are key components of the treatment for tobacco use and dependence. The good news is that the research has demonstrated that healthcare provider involvement definitely makes a difference. This is someone who receives no assistance from any clinician. You can get a small benefit if you give someone self-help material. It will increase slightly, but really you get more bang for the buck by having non-physician clinicians involved, like nurses and respiratory therapists, or physicians almost doubling the quit attempt for a long-term period. The news is also encouraging as more and more nursing research is being published that involvement of nurses will increase by almost 28% the probability of being quit for 5 months or longer. And again, we expect this to increase as more and more nursing intervention studies are done and published. As I mentioned before, this is the Helping Smokers Quit Pocket Guide that's included as part of your toolkit. It's organized according to the recommended 5 A's: ask, advise, assess, assist, and arrange. Stella and I are very proud of this book because we actually helped the Agency for Healthcare Research and Quality create the first book, which was called Helping Smokers Quit, A Guide for Nurses. It was so successful that when the 2008 Public Health Service Tobacco Dependence Treatment Update came out, they republished this, and now it's a guide for all clinicians. So let's review what these 5 A's are about. First is ask about tobacco use. Now, you know that it is important to find out about tobacco use, and frankly, patients expect you to ask about their tobacco use. Remember, 70% of all smokers do want to quit. You want to ask about their tobacco use because it has the potential to interact with some of their medications, and in fact, it may be directly related to their reason for admission in the hospital or their reason for seeing their primary care provider. The next A is advise. One of the most important things that you can do is to quit, and I can refer you to people who can help, or resources or others. This is a time to tell patients about the exciting news of a variety of medications that are available to help blunt the smoking cessation withdrawal symptoms that many of them have experienced, and to let them know that if they receive assistance with quitting, that they're much more likely to be able to stay quit for the long term. The next A is assess, and that means to assess readiness to quit. Remember, 70% are interested in quitting, and if patients aren't interested in quitting at the moment, you may want to explore with them whether or not they ever plan to quit. Maybe they've had some bad experiences in the past in terms of quit attempt, or don't know about the current medication. They may not know about it, how it might benefit them personally based on their health status. They might have some concerns and fears about what might happen if they quit. So this is a time to explore readiness to quit, but regardless of readiness to quit, every smoker deserves a tobacco dependence treatment intervention, and even though those smokers who are not ready to quit can be referred to the telephone quit line, which I'm going to be telling you about shortly, so that they at least have the resource that they can make the call when they're ready. Now, in terms of assessment, some of you may not have the time for comprehensive assessment, and that other clinicians can do that, including the counselors on the California telephone quit line. So we want to talk about that in a little while. But I also want to tell you that you can ask this in a sensitive, non-judgmental way. Again, we're we're about providing tobacco dependence treatment for a very serious high-risk behavior, and that's why nurses need to address it. Assess is the next day, and that's assessing tobacco users with a quit plan. Now, in the ideal world, if you were in a primary care outpatient setting, you would plan with patients to quit smoking, and they would get their ducks in a row, and then make a quit attempt 2 weeks later. In the hospital setting, it's a little different. Already, they're in a forced quit attempt because they're in a smoke-free environment. You want to address right away nicotine withdrawal symptoms that they may be experiencing, and what you want to do is to ensure or support long-term quit efforts after they're discharged from the hospital, to discuss strategies for getting support for family, friends, and coworkers, to review past quit attempts. Most smokers need 3 to 5 times of serious quit attempts before they're able to sustain being smoke-free. You want to help anticipate challenges, especially during those first few weeks where they're going to be having nicotine withdrawal, and importantly, personalizing it for the patient, discussing their reasons for quitting and the benefits for quitting regarding their current health status. Now, one thing we know in terms of providing advice for quitting is abstinence is essential, not a single puff. Again, no such thing as a safe cigarette. Even smoking one cigarette is associated with increased health risks, and taking a single puff may lead to relapse to more smoking. Drinking alcohol, definitely associated with relapse. Again, we don't have to smoke in bars right now, but drinking alcohol does lower our reserves and makes it more likely that patients may relapse. Also, other smokers in the household might hinder successful quitting. This means that there needs to be a discussion in the family about how are the best ways to support one another during the quit attempt if the whole family doesn't want to quit at the same time, and that's another option. Again, this is a time to discuss the variety of pharmacotherapies that are available, if not contraindicated, to let people know about an underutilized resource, the 1-800-QUIT-NOW, which is the national number, and California smokers can also reach it if they call 1-800-NO-BUTS. Either way, if they call the telephone quit line number, they'll be triaged to the California support system. This is free, no cost to the patient, and underutilized. Other free materials for patients are available from the Agency for Healthcare Research and Quality, and on the tobaccofreenurses.org website, we have a number of fact sheets and links to other materials specifically for nurses that may be helpful as you tailor your care plan for different patients. Now, perhaps the most important A is the last A, and that is arrange for follow-up. After people make a quit attempt, they need to have some sort of follow-up because relapse happens in the first few weeks after quitting. Relapse is not a failure of the smoker. It's not a failure of the quitter. It is, of the healthcare provider. It is important to use the relapse as a learning experience, to encourage a repeat quit attempt, to discuss what happened, what were the circumstances that led to relapse, to reassess pharmacotherapy, and to refer to other resources. And one of those resources might be a hospital-based cessation service, if you have that at your institute, a local program. Sometimes the American Cancer Society or American Lung Association have programs. Some of the medications that patients may be taking for smoking cessation will have free supportive services. There are web-based programs. Quitnet.com is one program that provides a free basic service, and importantly, the national quit line, 1-800-QUIT-NOW. This is a national quit line, meaning smokers all over the country can call this quit line, and then they're triaged to different resources. In our state, they're triaged to the California telephone quit line. Now, this is an easy way to integrate tobacco cessation interventions into your everyday practice. You can refer patients to a Quit line. It's effective. It's at no cost to the caller. Patients receive one-on-one counseling and follow-up from trained counselors. They receive free materials. We know that patients who use telephone counseling, as opposed to patients who don't receive any sort of support, are more likely to quit. Initially, patients have an intake that lasts about 40 minutes where the counselor gets the detailed type of information about their previous smoking and quit attempts, and then they receive follow-up calls to help for relapse prevention and for the added encouragement and support, which is so important to increase quit rates. Here is information about the California Smokers Quit Line. We have put this gold card in your toolkit. This is something that you can hand out to your smokers that provides information about the telephone number. Then, also, the Agency for Healthcare Research and Quality has the 1-800-QUIT-NOW cards that you can also distribute. Either way, they're going to get to the California Quit Line. The California Quit Line is available Monday through Friday, 7 to 9, Saturday, 9 to 1. They have voicemail 24 hours a day, so it really provides almost around-the-clock service. You also have other materials in California Tobacco Control Program, Tobacco-Free California, that provide free materials that you can use in supporting your patients. And of course, we want you to know about the Tobacco-Free Nurses website, especially the HelpingSmokersQuit.org tab. Since this tab is only for nurses in this special program, in order to access it, you need to type in HSQ as your username and HSQ as your password. Well, if we haven't convinced you already, why should nurses in California address tobacco use? We hope that you understand it's one of the most important things that you as a nurse can do to protect the health of your patients, and that each of the 435,000 nurses in California help just 4 smokers quit per year, just 4. We could reach 1.7 million, or 45% of the almost 4 million smokers in the state. So even though our overall rate in California is certainly something to be envied, and it is low, because we are such a populous state, we have many, many smokers, and we know that nurses, if trained and who are confident in delivering smoking cessation interventions, can make a huge difference in their patients' lives, and that if each of the almost 3 million nurses in the United States were to intervene with the almost 45 million smokers, we could definitely make a difference. Now, this is a picture of the Tobacco-Free Nurses website, and here is the Helping Smokers Quit tab. I also want to let you know that there are many other resources on the website. We have a specific library on the website which has publications written by nurses and about nurses in the area of tobacco control. There are also free media materials and fact sheets that you can download, including linking to the Agency for Healthcare Research and Quality Helping Smokers Quit pocket guide, so that you can get some of those. When you link to the Helping Smokers Quit, you will be able to link directly to California resources by pushing this tab. Again, nurses in West Virginia and Indiana have their own separate tabs. We also have a place for frequently asked questions. We're giving you lots of content today, and after you leave the program, you might think of some other questions. We will have a question and answer period, but please go to the frequently asked question area. We are always adding to this, and it might answer one of your concerns. We also have links to the Treating Tobacco Dependence Clinical Practice Guideline that provides the detailed, comprehensive information about evidence-based practice as well.